All right, good morning, everyone. This is our Unit 2 discussion. So today is March 14th. Let's get into our assignments here. So this week, these are your assignments due. Don't forget your first discussion post is due on Wednesday, and then you need to respond to 2 of your peers for full credit by Sunday evening. I do understand that there was some of a Herzing outing on Canvas or whatever it was that kind of prevented some of you from finishing up some of those assignments from Unit 1. I did make an announcement post about that, but you can still submit those. Just try to get those in ASAP. You don't want to fall behind on any of these assignments either, okay? So here are Unit 2 objectives. This is what we'll be talking about, and your assignments will be over this week. So pretty much every unit is going to be describing the roles and responsibilities of the surge tech, right? This is basically Surge Tech 101. You need to understand what you can and can't do. So every week we'll be discussing that. We're going to talk about surgical conscience and how it applies to you, what that term means. We're going to demonstrate proper hand washing techniques. So you actually have one of your assignments is to demonstrate that for me in a video. If you have any comments or concerns about that, please just send me an email. We can work something out. Talk a little bit about HIPAA laws and ethics. Again, we talked about that in Unit 1. And then talking about the concept of asepsis and sterile technique and what those terms mean. So starting off with basically the sterile portion of this, how do I know what I can touch in surgery? So it kind of goes to learning what your role is as a surgical technologist. Going into an OR can be very intimidating, especially if you've never been in an OR before, or maybe one that you remember. Maybe you were one as a patient, but a lot of times you don't remember, right? So it can be overwhelming stepping in that OR for the first time as a student. Knowing what you can and can't touch is a big deal, right? Because it pertains to the sterile field and keeping that patient safe. So what are some of these terms, okay? Learning sterile technique, what does that mean? So sterile technique is a practice that involves strict, very strict care to prevent the introduction of microorganisms into the sterile field. So what are microorganisms, right? Those are those invisible things you can't see. Micro is small. So that could be bacteria, viruses, it could be a prion or some other small living organism that could cause a disease or injury to the patient. So we want to prevent that. That is one of our main goals as a surge tech, okay? So 3 terms here that relate to sterile technique. The first one is asepsis. So if you use your med term, if you always have that little prefix A at the beginning of a word, A means without. Sepsis is like an infection within the body. So without infection is kind of what this is referring to. So it's referring to the practice of keeping things sterile, keeping things without infection, without contamination. So asepsis is the practice of, okay? And then the second one here is it's describing techniques or procedures. How do you go about something that will keep things sterile? That is asepsis or aseptic technique, okay? So sterile, you'll see this term a lot because, again, it's really what our job, one of our main jobs as a surge tech is to keep things sterile. So that word means the absence of all living organisms, including spores. That's the key there, okay? Including spores. Because some things can be considered clean or surgically clean, but they didn't kill the spores. So a spore is something that a bacteria can make that like basically puts like a little dome around it, a really hard protective dome around this bacteria that allows it to adhere to that surface of whatever it is and stay there until conditions are right for it to start to replicate again. So it's dormant. It may not necessarily be reproducing or causing disease at the time, but if conditions become favorable, let's say in a warm, moist wound, for example, then it can start to cause infection. So we want to eliminate those spores in the sterilization process. So anything we use in surgery that goes into an open wound, something that is invasive, has to be sterile. So we don't introduce those spores or living organisms into the wound. So sterile also describes the environment surfaces, whereas asepsis described the technique or how do you do it, Okay, how do you keep things sterile? That is asepsis. Sterile is describing the condition of, okay? And then contaminated is basically the opposite of sterile. Sterile is, there is no gray area with sterile technique. Something is either sterile or it isn't. There can be no semi-sterile, right? Either there's a living organism on it or there isn't. There's no in between, okay? So there can be no question as to whether or not something is sterile. If there is a question on whether something is sterile or contaminated, we use the phrase, when in doubt, throw it out, okay? So never question. If there is a question on whether or not something is sterile, just get rid of it. It's better to be safe than sorry, right? So contaminated means that there are some living organisms on whatever that sterile surface was. It's no longer sterile, okay? It came in contact in one way or another, inadvertent or on purpose, with that non-sterile surface. Okay, so what would the sterile field be? So in surgery, everything in that OR is not considered sterile, okay? There has to be some non-sterile things, like there are sterile individuals that will be scrubbed in the procedure, and then there are non-sterile individuals. So the circulator and anesthesia are going to be considered a non-sterile person, non-sterile personnel. They are responsible for things outside of the sterile field. The surgeon, the surgical technologist, assistant, resident, whoever else is scrubbed in is considered a sterile individual. They are the ones that can come in contact with the sterile field, okay? So I put these three pictures up here just to demonstrate what some of those sterile fields are. The center of the sterile field, which I didn't put a picture of here, but the center of the sterile field is the surgical patient. Once we get that patient positioned, prepped, and draped, put that drape over top of it, that sterile drape, that's the center of our sterile field. Now we have other things surrounding that we need to work off of or, use within the procedure that does have a sterile drape on it, still part of the sterile field, okay? So you as the surg tech or surgeon, whoever, that has a sterile gown and glove on is part of the sterile field. Okay, so what is sterile on this gown? We'll learn more about, gowning and gloving and that process later, but just to give you an idea, heads up, okay? So with this gown, I tried to highlight it here in yellow, okay? That is within this yellow area is the sterile area of the gown, okay? So up here on the shoulders, the neckline, the back side of the gown, and below, let's say the umbilicus, is not sterile, okay? You could not touch those areas. Even though you have the whole gown on, you can't touch those areas. So the sterile part is 2 inches above the elbow, all the way to the fingertips, and then about mid-chest, right about to the umbilicus, or if you like feel the top of your hip bones and go straight across, that would be part of that area. Now it cannot extend to the back of the gown because you can't see the back of the gown. It just goes just to the side, okay, to the lateral edge. It's the only part of the sterile gown. So when you're scrubbed in, once you've put this gown and glove on, you can't be touching anything else or you've contaminated it, okay? Just because it's outside those boundaries, you can't cross the boundaries, okay? You can't be touching your mask, your hair, you can't scratch an itch on your ear, okay? That's part of learning some discipline with sterile technique. All right, the sterile back table is also part of your sterile field. So the sterile table that we covered, you put a cover on top, maybe from your pack, your custom pack or whatever it is you're using with supplies in it, will cover this back table that we use for things that we need throughout the procedure. So it is only sterile on the tabletop level only, okay? So if you are trying to move this table, maybe bring it up to the patient, you can't be grasping under the edges. You have to keep your hands like straight on top and slide it that way, okay? You'll see people do it wrong once you go to clinicals, but that is the correct way to do it. That is tabletop level only. You cannot reach or have anything hanging below that sterile level tabletop, okay? And then this other one here, I wanted to just demonstrate that there are going to be some supplies open to you in the procedure, throughout the procedure, that have been sterilized in a special like muslin wrapper. which you'll learn about in another class, how to do all that stuff. But when they open these, this person is the non-sterile person opening this sterile supply, so care has to be taken, right? You don't want to accidentally contaminate the inside of this sterile wrapper. So what is sterile is basically everything inside up to 2 inches of this border. So notice they can grasp just within that border edge to open it. She can't be, or he cannot be reaching inside and touching this. That would contaminate the inside and potentially contaminate what's been wrapped. So learning how to open those sterile supplies in a manner that doesn't contaminate the inside is important as well. So this one, it's hard to see from here, but they opened this flap away from them first. That way this covered edge on the bottom side is still protected from the non-sterile person. Then you open flap side to side, and then you open the flap that's closest to you last. So you're not reaching over any sterile field. A contaminated, or not contaminated, I'm sorry, a non-sterile person can never reach over a sterile field that also considers it contaminated. Because, for example, if you didn't have a jacket on and you reach over, your skin could actually slough off, even if you can't see it, and like kind of slowly drop to the sterile field. So we have to be aware, even though we may not see it, perfectly, that, oh yeah, skin cell just dropped on the sterile field. We understand that that could happen by reaching over a sterile field as a non-sterile person. So then we automatically know, okay, that's contaminated. Then we have to take steps to fix that. Okay, so maintaining the sterile field, once you set up that sterile field, how do we maintain it? Okay, again, one of the most important duties as a surg tech, that's the majority of your job. Okay, a lot of people think, oh, you're just passing instruments, right, in surgery. No, it's a huge deal making sure that everything in that room stays sterile for that patient. Okay, you're going to be watching people like a hawk. Okay, you're not just looking at what you're doing, you're also looking at what everybody else has to do, because you have to prevent, recognize, and correct any breaks in sterile technique, not just from you, but from anybody. If you see that that surgeon accidentally touched the light instead of the light handle, that's sterile. You have to say something. It may be uncomfortable to approach a surgeon that you think should know better, right? Mistakes happen. They would rather you step up, be willing to say, okay, you know what, this is contaminated, instead of him hawing around about it, and then they knew they contaminated, but maybe they were testing you. Sometimes preceptors, even surgeons, will do stuff like that to surgeons or to surg tech students. They want to see if you have that surgical conscience about you, okay? Whether or not you're willing to step up and speak up for that patient if something does get contaminated. So be very conscious of that. It does take a little bit of time as a surg tech student to start to recognize those things, but once you do, you are responsible for that knowledge, right? You have to be willing and brave enough to step up and say, hey, you know what, this is contaminated, let's fix it, okay? So again, with maintaining the sterile field, one of the ways we do that is by recognizing strike-through contamination. So what does that term mean? Okay, strike-through. It is fluid that goes from a non-sterile surface, goes through a wrapper, protective wrapper of a sterile item that now causes it to become contaminated, okay? So let's say the patient is draped with a sterile drape. We're working in surgery, maybe a tiny hole or whatever got put in the top drape. Now, anything that was below that top level that may have gotten wet, let's say, from, it really doesn't even matter from what, and now it's striking through to the top layer, okay, that on top of that sterile wrapper, that is strike-through contamination, okay? Our surgical gowns should not allow for that strike-through contamination. If it does, you are now considered contaminated. So these protective wrappers, like our patient drapes, our gowns, our back table covers, are what we call impervious. So it should mean that water fluids should not be able to pass through those layers of that particular fabric wrapper, okay? Now, if it does for some reason, maybe over time it broke down, maybe it's a long case, whatever, and that fluid strikes through, that's strike through contamination. So then the entire surface is contaminated and we have to fix that, okay? Also wanted to bring in this term SSI. I'm sure heard of an SSI. Okay, it stands for surgical site infection. This is a huge concern for our job and our patients, making sure that they don't get an SSI whatever we're doing in surgery. So the most common cause of an SSI is a particular bacteria called Staphylococcus aureus. Okay, it can lead to really gross, I tried to pick a good one here, really gross infections in the skin where we made that incision. It could even go deeper into the tissue, into the bone. So why this is such a concern is, A, you're delaying their healing, right? That patient may have to come back multiple times to have this fixed. They may have to have, extra surgeries, or your patient could already be immunocompromised. That means they may already have other issues going on that prevent them from fighting infections really well. So their immune system's already depleted. So if we're introducing more bacteria and that causes their body to have to fight extra hard, it may be even harder for them to fight off and it may actually lead to death. So it is a huge deal. Diabetic patients have a really hard time with wound healing. We don't want to make it any harder for them. We don't want to cause unnecessary subsequent surgeries or, hospitalizations or even death. So making sure that we maintain a sterile field to prevent these SSIs is super important. I can't stress that enough. Okay, part of also maintaining the sterile field starts before we even set up the sterile field. Okay, it starts with the basic hand wash. Now your hands, your skin as it is cannot be considered sterile. Okay, that's important to remember. Your skin, because it is a living organism already, cannot be considered sterile. You also already have normal, what we call resident bacteria on your skin already. Those bacteria should be there, right? They actually have a good function. They help keep the bad bacteria away. So the basic hand wash, as well as the surgical scrub later, will help reduce the bad bacteria. It can never get rid of all of the good bacteria because it's supposed to be there. So skin and living tissue can never be considered sterile. Now the basic hand wash is just trying to reduce what we call transient bacteria, the bacteria that shouldn't be there, the bad bacteria. So it is one of the most important tools in preventing infection, just your basic hand wash, because we touch a million things a day, right? You can't go from, cleaning up a patient without gloves on and then going to touch the door. Other people will touch that, then we end up getting, spreading germs and infections, right? So the hand wash is considered event related. So that means, if your hands are visibly soiled, you can see, I've got a little bit of dirt on my fingernails, whatever it is, you have to go wash your hands. If you just came back from the bathroom, obviously, you have to wash your hands. After you eat, if you're one that goes outside to smoke, when you come back inside, you have to wash your hands. So these are event related things that you have to do in between each patient, after every surgery, before every surgery. When you first go into the OR for the day, you should be doing a basic hand wash before you ever do a surgical scrub. Okay, we want to reduce the amount of bacteria present. This should only take about 30 seconds, whereas the surgical hand scrub should take, if we're doing a time method, about 3 minutes. As a student, I'm sure it will take you longer. Don't be discouraged, okay? But once you get into it, it'll take about 3 minutes. Okay, so here are the steps to the basic hand wash. You will have a video in which you need to demonstrate that to me. So you're just going to wet the arms, you're going just above the wrist, 2 inches above the wrist. You don't have to do the whole arm. That's the surgical hand scrub. You're going to use some sort of antiseptic, soap, or hand wash. Cover all surfaces, rubbing together. You're going to go in between each finger. You're going to get the backs of the hands to 2 inches above the wrist. And you're going to basically rub your nails into the palm of the other hand. Obviously do both sides, okay? When you're ready to rinse, you're going to sing, you could sing happy birthday. That will give you about 30 seconds, whatever little ditty you feel like singing, okay? that will maybe pass the time for you. So you're going to rinse your fingers pointed down under the water, and all the germs are going to then run off of the fingers. Okay, that gets them away from where you're going to be touching. Then you can just dry with paper towels. Okay, so here's a little demonstration video. I know basic hand washing is pretty, elementary. You should probably know how to wash your hands by now, but it is a skill that you need to check off on. And that's just something basic that they expect you to know how to do when you go into clinical. So let's just watch this real quick.
So let's review a basic hand wash. Now, a basic hand wash, you're going to do several times in the day, like after you eat, after you go to the bathroom, when you first walk in during the day. The purpose of the basic hand wash is to clean off as many transitory microbes as you can, to get your hands, pretty clean. That's the goal. It's not going to be sterile, obviously, but it's going to be pretty clean, at least safe enough to use in the hospital. Now, the first thing you're going to do is you're going to inspect your hands and check to make sure that there are no cuts or abrasions or anything like that. And right now, mine look okay. So the next thing I'm going to do, I'm going to wet my hands like that. Go up to the wrists and past the wrists. I'm going to get some soap.
Now, if we're being picky, you should take that ring off to scrub. That's by the book, but just wanted to point that out.
And rub the soap in, okay? See, normally people will wash their hands like this, and then they're done. But no, what we want you to do is we want you to get in between your fingers. So you're going to get in between your fingers like this. We want to rub the back of your hands like this, down around the wrists, all right? The back of this hand and down around the wrist like that. Between the fingers, get all those webbing areas, all right? You're going to soak that up real good, and you're going to do this for about 15 seconds. So in other words, the way to remember 15 seconds is sing happy birthday to yourself. So happy birthday to me, happy birthday to me, happy birthday dear Mark, happy birthday to me. Now if you want to make sure, I don't know, maybe I sung that a little fast, but you can also sort of rub your fingernails, get under there a little bit, maybe clean out. Check under the fingernails to make sure you don't have anything under there. And when you're ready to rinse, you're going to rinse from your wrists down to your fingers. So the water is going to drain this way. This is going to be different from what we're going to do in a minute, but right now we're going to rinse this way. So I'm going to put my fingers in here and rinse with my fingers pointing down. I can rub them in order to get all the soap off, but the fingers remain pointing down. Pull my hands out, I can turn the water off, and I can go and dry my hands. Dry my hands, and then I can throw them away. And that's a basic hand wash.
All right. There you go. Pretty basic, but we do need to see that you understand the concepts of how to do it and when to do it. All right. So moving on to the surgical patient. Remember, that's the whole point of our job is the surgical patient. If you can get that in your head, everything else falls into line, okay? You have to remember that every patient is unique and we want a positive outcome. It's patient-centered care. Everything is revolving around that patient, okay? The surgical team is then going to base assessments, planning, any intervention on the individual. There isn't a cookie cutter way to do surgery because everybody's unique. Everybody's anatomy is different. So you have to plan for those things. Every consideration you make has to be about that patient. So what I always tell my students is to think about your most loved person. Okay, picture whoever that is. Some of my students say it's them. That's fine. If it's you, that's fine. If it's your grandma, your son, daughter, husband, wife, whoever it is, whoever is that most loved person in your life that you hold higher than anybody else, every time you go into surgery as a surg tech, I want you to picture that person laying on that table, because then your actions are going to reflect that. You will make sure that everything you do is for that most loved person. You're going to speak up for those contaminated items. You're going to speak up to that angry surgeon and say, hey, you know what? This isn't right. We need to fix it. It's going to give you that courage and that surgical conscience that you need to make sure that that patient is first, okay? It can be a little hard to sometimes wrap your head around that, that's my most loved person laying on that table. But think about that person. That is somebody's most loved person in the whole wide world. That is someone that is somebody's mother, father, son, daughter, whoever, okay? Keep that in mind that, this isn't just a patient. This isn't just, you'll hear preceptors or even surgeons say, oh, it's just a colonoscopy, right? It's just no big deal. We'll be in and out in 10 minutes. It's not just, okay? It's never just. That just colonoscopy could be them getting news that maybe their cancer returned, their colon cancer came back. So it's never just. Keep that in mind. Okay, along those lines with the patient, we are going to discuss Maslow's hierarchy of needs. Maybe you've heard of this before. It's developed by Abraham Maslow. This little triangle is just showing an individual, in our case, a surgical patient, and their needs. So we start at the base of the triangle. Everything in our lives is starting at this base of the triangle. You don't have this, nothing else falls into line. So at the base of the triangle are physiological needs. You have to meet physiological needs before you feel safe. So if you're hungry, if you don't have food or water, you're not going to feel safe. You're not going to be secure, right? And once you feel you've met all these physiological needs and you can then move on to safety needs, if you feel safe and secure, then you're going to start to develop these relationships. You're going to feel like your physiological needs, your mindfulness is being met. You can then start to feel like you have some esteem that is being met with sense of accomplishment, whatever it is. And then you can move on to the very pinnacle, the very top is self-actualization. So you're at your top, okay? You're at your full potential and you are fulfilling, all of your needs, including creative activities. So what's important to remember here is that once you, theoretically reach the top, it doesn't mean you stay there, right? I think we've all realized that, oh man, one day we're doing great, and then something happens in the next day and we jump back down to here, and some of these don't feel like they're being met. So it isn't a one and done situation. Same with our surgical patients. They're going to come in to you into the OR and they're going to need some physiological needs met. Obviously, that's, one of the main things we're working on is the body, not necessarily psychological, although we can meet those needs in the brief time that we have maybe a conversation with them. We are super concerned with making sure they're getting their nutrition met so they can heal, making sure they're warm, making sure they're safe, okay? We're not going to necessarily be able to build friendships with them, although we can make sure they belong and make sure that they feel like they're being heard if they're voicing concerns. So we can affect that to some degree. So about those patients' needs, okay, a lot of our patients, understandably, are going to come into our OR feeling afraid. I think that's a natural thought, to be afraid to come into surgery, whether they're afraid of anesthesia, whether they're afraid of being awake during the case, or maybe not waking up. Maybe they're afraid of what happens afterwards. I had a patient once who came into the OR and they were so worked up. She was in tears. She was having some OBGYN procedure. I don't even remember now. And all she could think about was how she has to be able to recover quick enough to be able to go home and do the house chores for her husband, because he would get mad if it didn't happen. So, you don't always realize what these patients are going through at home. And when they come in, they start to talk to you about these things. Maybe you're an unsterile person in the room, maybe you're helping the circulator, whatever, you can be up at that patient's side and supporting them, okay? You can be calming their fears, talking to them. If they're okay with it, you can hold their hand, maybe ask. Some patients don't like to be touched like that, so be mindful of that. But we can support the fearful patient. If they're voicing concerns about anesthesia, you can reassure them and say, we're going to take the best possible care for you, and let's talk to our anesthesiologist about some of these concerns, okay? What you never want to do is say, you know, we're going to cure you. Everything's going to be fine, because we honestly cannot make that promise. We don't know if everything's going to be fine, but we can tell them that we're going to do the best that we can possibly can to take care of them. Okay, they're concerned about pain management. That could go back to being fearful. So some patients come in and they're already in pain. They can voice that to you, and you can direct that concern to anesthesia and say, we're going to take care of your pain, okay? Sometimes you'll be working with peds. Not all facilities do peds, but if you do, children have a whole other set of needs, okay? So think about, you know, that 3-year-old that maybe comes in for a tonsillectomy or an ear tube. They're not used to being separated from their patient, and they're going to revert back to that like infancy stage where they need that parental or that love, okay? So you're going to support a fearful child a little bit differently than a fearful adult. So keep the patient in mind as to what maybe age appropriate needs they need. Sometimes, you know, we can distract them with, you know, blowing up a hand balloon, or if it's an infant, you can obviously hold them while they go to sleep. There are different ways to manage those things. Supporting patient communication, again, like I talked about with this fearful patient, always communicate what you're doing. If the patient comes in and they're awake or aware of what's happening, you can talk to them and say, hey, you know what, we're going to place this safety belt across your legs just to keep you safe. They want to know that their safety is being met. They want to make sure that, you know, they're in the best possible care, that we're taking those steps for them. So communicate everything you do, because when a patient comes into the OR, they're going to be feeling probably very overwhelmed. Everybody in that room is doing their own thing. They're kind of like running around like a little beehive. Everybody has a job, and they're doing that job. But sometimes we forget that that patient, the center of our care, right, is very overwhelmed and scared. So if you are back, you know, setting up your surgical table, your sterile back table, make sure that you are aware that that patient could see you, and they might be scared of this giant back table full of drills and knives and stuff. That is scary. So maybe take that just a few moments to maybe stop what you're doing, address the patient when they come in the room and say, hi, my name is so and so. I'm a surgical technologist. I'll be helping taking care of you today. Just you know, acknowledging that that patient is there is important to them. Okay, if they're saying that, you know, they're very scared, you can try to comfort them. You always tell them, you know, I'm going to be, you know, putting something on your leg, or I'm going to place this blood pressure cuff. Don't just come at them. Everybody's coming at them, right? So just kind of keep them in the loop. That calms their nerves. Okay. They also want to be respected and have that privacy. So if the patient's still awake, we're like positioning them, putting warm blankets on them, whatever. You don't want to immediately just throw their legs up into stirrups while, you know, while they're awake. We want to make sure that their privacy is met. We want to respect their wishes as well. So maybe this patient asks for no men in the room if it's a woman. We have to respect those things, right? And being a part of us, you know, part of our job as a surg tech, even if we don't necessarily agree with something that the patient wishes, we still have to do it. We have to respect those patient wishes. And we always want to maintain privacy for our patients. That kind of goes back to the HIPAA laws as well. All right, so this is our Unit 1 discussion. So if you have any questions about this chapter or any of the assignments as you go through, feel free to send me an email. I do have office hours today, Tuesday, from 12 to 2. If that doesn't work for you, get in touch with me and we can work something out, okay? So again, feel free to ask any questions. I will try to help you as best as I can. All right, have a great week. Bye.